Good day everyone, I am Michael, the moderator for this webinar. I welcome everyone for today's webinar, which is Mastering the 2024 Prior Authorization Process for Medical Providers. It's a great pleasure for me to introduce our presenter for today, Tony Elhams. Tony Elhams, CCS, CPC, CPMA, CRC, AHIMA approved ICD-10-CM, PCS trainers, is an internationally known speaker and recognized subject matter expert on medical coding, reimbursement, compliance, and revenue cycle management. She holds multiple credentials with American Health Information Management Associations, which is AHIMA, AHIMA, and the American Academy of Professional Coders, AAPC. I would now like to hand over the floor to the speaker. Over to you, Tony.
Thank you so much for that introduction, and thank you to all of our attendees today. We're going to be talking about one of my favorite topics, prior authorizations, and how to navigate them in your medical practice. So basically, we're going to talk about some of the key challenges. There's a lot of traction, and prior authorizations is a hot topic in 2024. We're going to talk about the process, some of the methods that are used, the key challenges that exist in the prior authorization process, and strategies to combat some of those challenges. Considerations in the prior authorization process, that's a big part of it. The folks that are impacted by prior authorization changes, which happen rapidly and frequently. So let's talk about prior authorizations. Basically, it is a pre-approval process. The provider or doctor, physician, basically has to get advanced approval from the health plan, a third-party payer, before a specific test, procedure, service, medication, drug, device. They basically have to get their approval, and that insurance company they can have many different methods for prior authorization. Basically, you have to make sure you submit the request in the method that the insurance company requires. So if your prior authorization request is approved, then you'll be getting a PA number. So then you basically take that prior authorization number and it gets added to the claim when that claim is filled out, so that they know, we got your approval, you need to pay us for the services. If the request is denied, then you can appeal it, and there's different levels of appeal. And basically, the insurance company does this because they want to control costs. They want to ultimately restrict access to services, medication. So it's a major source of headache. Despite good intentions, or at least that's what the payers say, it has been criticized as causing enormous administrative burden, a lot of paperwork. We got to have full-time employees to do prior authorization checks, tracking, and then it causes delays in patient treatment. Key here is that a prior authorization is a denial of payment. It's not a denial of treatment, meaning the patient can still get the treatment. Their insurance company may not pay for it. And so that's really a key distinction that you have to constantly educate your patients on. It's manually intensive. It takes a lot of time. So most doctors believe that prior authorization protocols lead to unnecessary waste and avoidable patient harm. That's a lot of people that have been affected by unnecessary administrative burden. The AMA says that prior authorizations have bad outcomes and they ultimately delay care. Delays in accessing necessary care, 94%. Negative impact on patient clinical outcomes, 89%. Patients abandoning treatment, so basically saying, I'm not going to get that medication, I'm not going to get that test, 80%. The big issue is medical necessity. Did you jump through all of the hoops and meet the requirements that the insurance company set forth in their coverage policies? Now, Medicare, let's talk a little bit about Medicare. So Medicare, traditional Medicare Part B, Part A, does not require prior authorization. Medicare says no payment can be made for any expenses that do not meet medical necessity requirements. So they have to be reasonable and necessary for the diagnosis or treatment of injury or illness. So they come out with their coverage determinations, LCDs, NCDs, and then our commercial insurance companies have their own policy. The legal or the payer definitions of medical necessity, and so this is actually appealed to the Second Circuit. Now, physicians define medical necessity as healthcare services that a physician exercising prudent clinical judgment, meaning they're doing the right thing, they're practicing ethically, would provide to a patient for the purpose of preventing, evaluating, diagnosing, or treating an illness, injury, disease, or its symptoms. They also go further to say this is generally accepted standards of medical practice. So basically, this is an example of Humana, a Medicare Advantage, a commercial insurance company. So basically, the AMA did this study. They asked about serious adverse events. They asked about prior authorizations, how much time it takes, how much burden it is, what that impact is. Medicare introduced a landmark rule, the CMS 0057F, or the Interoperability and Prior Authorization Final Rule. They have a whole host of requirements. The problem is it doesn't go into effect until 2026. So when 2026 rolls around, we're going to have a whole new rollout of requirements. They've also added new categories for MIPS and the Medicare Promoting Interoperability Program. We have some expedited processing, which is great because I've had instances where doctors have went. There's a lot of hope. There's more support and momentum for prior authorization reform now than ever that are being proposed by the AMA are quick response times, so they want 24-hour turnaround times for urgent requests, make authorization valid for at least 1 year. So who's impacted? Our doctors, our healthcare providers, of course, coders, billers, auditors. When we see things, denials, appeals, your workflows are going to be, clinical documentation, medical necessity, being able to articulate that. So just to wrap up some best practice tips, make sure that clinical documentation is overstates the necessity. Specificity in your documentation and coding matters. Again, it can make all the difference. All right, so at this time, I would be happy to take any of your questions. Thank you so much for your time and attention today. I hope that this has been helpful. I hope you have a great rest of your day. Thank you so much.
Thank you, Tony. Once again, thank you so much for the great presentations. So that does conclude the session for today. Thank you everyone for participating. You may all disconnect now. Have a great day ahead. Bye-bye.